All right. They're probably not going to miss anything exciting. So faculty have a lot of roles and responsibilities. And it was interesting because like when I put this in, like put this together, I like was looking up the ACGME requirements and like the ACGME like core faculty job descriptions and ChatGPT and like all of this spit out. I was like, wow, that's a lot. But we do it all and we just don't think that like about it. Like we're doing it every day. It's just not something that like I bullet point on a regular basis. And so all of these things are things that you will be doing as core faculty. So there's clinical teaching and supervision. So Dr. Jones obviously talked about the supervision part of it. Resident education, evaluation and feedback. So feedback, right? Tell them that you're giving them feedback. Mentorship and advising. You'll do curriculum development, scholarly activity and QI, professionalism and role modeling, and then recruitment and selection, which is always fun, the recruitment part. So I'll get into each of these and describe them a little bit more in detail. So clinical teaching and supervision, obviously Dr. Jones just went into, I won't talk about the whole thing here. But obviously you're providing direct bedside and ambulatory teaching during routine patient care. A lot of the feedback that I get sometimes when I'm on the inpatient service is that they want dedicated time in the afternoon set aside to do their learning. And I'm like, okay, well, fine. But it also depends on how many admissions we get in the afternoon because patients come first. And I'd just like to reiterate the fact that rounds, if you're listening, is all teaching, right? Like everything that we're talking about during rounds is learning and teaching. And so it is just integrated into what you're doing every single day with all of the patients. Dr. Jones talked about patient safety and resident autonomy, so that balancing act, the supervision across the training levels, and just kind of adherence to all of the Medicare and ACGME requirements. So we'll hash that out even more. So resident education, there's structured teaching and then there's non-structured teaching. What we really want to do is reinforce the things that we're seeing every day in family medicine and what they could potentially come across in real life and on their boards and prepare them well to take their boards. We'll talk about this a little bit with the curriculum, but like longitudinal learning across all 3 years, we integrate certain aspects of their learning across all 3 years, not just like this is your second year learning, this is your third year learning, and so on. We're incorporating procedural training. We went over all of the procedures that are going to be required of them to be competent in, including POCUS. And then we have the ACGME milestones to help guide us on their evaluations that go out to the rotations. They're actually linked to the milestones. And so the evaluators are able to go through and kind of place them on that continuum of like where they are as far as along the continuum of the milestones for the ACGME. So evaluation and feedback, the goal is to provide timely, specific, behavior-focused feedback because if it's not timely, then it's not helpful to be like, you remember this thing you did 2 months ago? Don't do that. So they're like, what? So that's not helpful if it's, we want to address it in the moment if we can. We use the milestones to help guide us, but, we're not sitting down and being like checking the boxes on there with them in front of us. And so just kind of have a familiarity with the ACGME milestones in order so that you can kind of talk to them through it. If you're their faculty advisor, you'll go through some of that in their meetings, like your advisee meetings. Obviously, we want to promote a culture of the continuous improvement through formative feedback. So there's effective ways to give feedback and there's ineffective ways to give feedback. And that's probably a great topic for a different retreat because I think we had an entire class on that for our faculty development fellowship. And so it's not something that we'll breeze over. We'll talk about that more in detail. But you want to document any concerns. I get emails from outside preceptors, both good and bad. I got one yesterday from our trauma surgeons saying how wonderful one of our second-year residents is right now on service, he's wonderful. And then I get the ones that are like, I've had problems with this resident, I need you to know about it. And it's like, yay, get both of those. I love the good ones. But it's also important for us to know the not so good ones because we're not there to see it happen. So it's helpful for the documentation to be there so that we can give that feedback to the resident. And then the Clinical Competency Committee, or the CCC, that meets twice a year. We have a smaller core faculty, so all of our core faculty are on the CCC. It's not like that in all of the larger institutions, but so the core faculty will participate in that. The residents get a wellness half day usually, and then we get to sit and talk about them for 4 hours. So they get to go float down the Salt River, and we're sitting in there like talking about them. So I think you're gonna participate in our next one probably, so that you can get a feel for it. Yeah. It's a good question. I don't know if we've kind of figured that one out yet. Probably a little bit of both, because they will be, obviously part of our cohort, but they have specific things that we want to make sure that they're competent in too. And so honestly, we have mini CCCs for residents that are struggling, like during our faculty meetings a lot, and because we use it as like documentation that this was a CCC during our faculty meeting, so we can kind of pass that along to the resident, to GME, and so we can kind of see what works for the rural track. Yeah. So yeah. Mentorship and advising. So I mentioned this just before. So all of our residents have a faculty advisor that we assign to them. I try to assign them with things in mind, such as what their interests are, what their strengths are. The people who are really interested in like women's health, I put them with these faculty members because they're really interested in women's health, that kind of thing. So I try to match them so that it's not just like a randomly assigned, here, go advise this person, but there's some mutual interests there. We want to support their career planning, obviously. So whether that's rural medicine, OB, inpatient, academic medicine, whatever they are kind of looking for, try to foster that. Hopefully it's the rural part of that for our rural students and rural residents. We help guide them with their job applications. I don't know how many contracts Rex has read of our residents from his experience over the years. He goes over and helps, and it's huge. So the residents really appreciate that part of it too, is like not just academic, but the real world stuff about applying for jobs and what to look for and what to kind of look for in a contract. So all of this goes into being a core faculty member. And you have those longitudinal relationships over the 3 years, and it's pretty great. I remember all of my advisees from all of the years before I had to turn them over to Doug because PD doesn't have individual advisees, and so I had to give him my advisees. So you build really good relationships. Then curriculum development. So we're working on that already, obviously, with our Mariposa and Nogales surrounding area. Design and refine the resident curriculum. And so obviously for rural, we want to tailor that to the rural experience and to what they need. Obviously there's some parts of the curriculum that are ACGME requirements and ABFM requirements. But our goal is going to be with this curriculum is to integrate and incorporate the rural health aspect of it into the curriculum for the rural residents. They will have a few rotations that are required of them that maybe aren't required of the ones that are in Phoenix, and vice versa, because it's not helpful or conducive. So we want to really tailor it to what's going to be helpful to them. And then we continuously update curriculum based on outcomes and feedback. So I have changed rotations, I have moved rotations, I have changed like schedules to accommodate the feedback I get from the residents if it's a reasonable request or if it's a reasonable complaint. Because it's their, it's their learning. We want to make sure that they're getting the most out of it. And so what we can change if it's going to make a good outcome for them. I just shortened their ED rotations from 12 hours to 10 because it still meets the requirements, but they have to drive out to Surprise to do it. And so they were like, we're tired. Can I not be there for 12 hours? I'm like, I don't see why not. It still hit the numbers. So just little stuff like that, it actually makes them really happy, but it still meets all of the requirements. So we're flexible. Scholarly activity and quality improvement. And so QI projects are required of all of our second year residents. They're the ones who lead it. Everybody's involved with the QI projects in our clinic, but the second years are the ones who spearhead it. They come up with the ideas. They have their color teams. So we're split into 4 color teams within the residency. And so their faculty on each color team helps to mentor their QI projects. It's great for those of us who have to continue our board certification because QI is actually a required part of our ABFM board certification and it counts. But the residents get to understand like why we do it, what we do, how to do it, all of that. And it usually we have them present at academic excellence days and things like that. There was one very similar kind of event yesterday down at the U of A. So the residents will present that, but obviously our job as faculty is to help them with those and help guide them to interpret the data and, picking out projects that are going to improve patient care and quality and not just like, oh, this is going to be easy, so let's do it this way. So scholarly activity and quality improvement. We have one of our core faculty in Phoenix who's really, really excited about all of this. And she's out on maternity leave, and I feel that absence. I'm like, oh gosh, I don't know what was planned. So if you've got a really strong interest in research and in scholarly activity, please let me know. Professionalism and role modeling. So we were talking about this earlier. Dr. Jones was mentioning this, that like sometimes it's literally just walking into the room and talking to the patient like you normally would, but the resident's watching you. They're always watching you. And so how you interact with patients and how you interact with other professionals and the interdisciplinary team is what they're going to kind of internalize as how they should act and how they should practice medicine. And so you want to maintain all of the aspects of professionalism that you would want in your residents going out and graduating, or who you would want taking care of your own family. So as you want to kind of emulate that for them. And then if there's issues, there's always some professionalism issues that pop up here and there, whether it's late to rotation, didn't show up on a day, didn't call, whatever that might be, you want to address it promptly. Again, don't tell them like you didn't go to your rotation 2 months ago. Why didn't you do that? And they're like, so promptly and constructively. So role modeling that professionalism is very important. Recruitment and selection. So recruitment season seems like it's never ending. And we interview all these people and then we have match and then there's a lull and then we're like, wait, we have to talk about recruitment for next year. And so then it starts again. And so really we want to have people participating in the recruitment and so the review of the applications, putting your opinion out there because we value everybody else's opinion as well. We want to find really great residents that will fit well. It's going to be extremely important for our rural sites to get residents who are very excited about rural medicine and want to be there. And you're going to be the ones helping me find those people. So going to things like residency fairs, like the Future Conference, and kind of putting us out there and letting people know that we have a rural track now and we want residents to come with us. And so it's the recruitment season technically starts in September when the applications come in, but it really is all year round. Like we're in this like middle zone right now, but we had a residency fair yesterday. And so it's never ending. And you really just want to put your best foot forward so that the residents see that. But we also want to recruit and select people who are going to be good fits for our program. So that's the expectations. So how are we going to support you in all of these things? So faculty support, obviously extremely important. We have a lot of faculty development things available through Creighton. So Dr. Jones is co-instructor for our for our faculty development fellowship through Creighton. Myself and Dr. Hill, our APD here in Phoenix, went through it, the very first cohort, and we've had one or two of our faculty each cohort go through, and it's been great, and they learn a lot. And so when we know more about the next cohort, we'll pass that along. But there's more than just the faculty development fellowship. There's all sorts of other support. So teaching skills workshops, there's academic promotion guidance through the university, scholarship and QI mentorship, obviously, like I was saying. You'll meet with me twice a year. We'll go over evaluations, discuss your career goals, that kind of thing. I think Dr. Jones asked me like 4 years ago if I'd ever thought about being a PD, and I said, nope. He's like, what are your goals? I said, this. I was the inpatient director, and I'm like, that, I'm good. This is my goal. And well, here we are a couple years later. So it's important to have those conversations because I had never thought about it before then. He's like, you might want to think about that. I'm like, okay. So important to have those discussions with each other. The GME office is a resource. There's lots of very smart people in our GME office that are available for guidance, discuss all sorts of stuff. There's CME funds that you have available that we can help with, like memberships to our teaching. So STFM, the rural health things that we're already kind of a part of. AFMRD, which is the Association of Family Medicine Residency Directors, the AAFP, AZAFP. So we have support from all of those different things and from Creighton to kind of help with that. We have program manager support. So obviously that's very important as well. The GME office has very experienced managers and coordinators that have been a resource for our manager here in Phoenix. And so, you all work together and kind of bounce ideas off of each other and ask for help. And it's really great. There's also memberships for our programs managers, the AFMA, rural GME, all that stuff. So things are available for you all. So the faculty development, I talked about the fellowship. There's also access to things online, so kind of on-demand learning, access to Blue Line and YouTube videos. Probably this will end up on the YouTube thing. And then whenever new faculty start, I give them a binder, and I'm like, here, have fun with that. It's got all sorts of stuff in it, and I should have brought one as an example for today, but I'll give you one another time. But it has just everything from the basics, which is literally like the pictures of the residents, so you know who you're talking to, and their phone numbers, to like who's their advisor, to things about like precepting, to resources, ACGME requirements get printed out and given to you. And so just kind of a quick guide. I also give you a book that is a book on like helping the struggling learner, I think is the one that I give. So all of our new faculty get that. So we try to support and help with all of that. So this is the Blue Line. So this is your link to the Blue Line. This is what mine looks like when I pull it up. And so there's modules, there's things that you can click through. So this is through Creighton. And then this is the YouTube, and I can scroll through it later if you want, but this is just a screenshot. So you go to this YouTube channel and there's all these on-demand videos. You can watch them. And there are ways that you can report the CME that Dr. Seaman knows about, that she told us during our faculty development fellowship, and I can't remember how to do it, but you can email her and ask her, how do I get CME credit for these videos that I just watched? And she'll send it to you. So it's available for you.